aging, AACOG for short, and she's going to talk about Medicare Part D. So please give Dana a warm welcome and your attention. Thank you.
Okay. Is it on? Is it working? Can you hear it? Is it on? Okay. All right. Yeah, let's just use that. Let's just use the mic, and I have a loud voice anyway. Okay, as you're saying, I'm from the, nobody ever gets this right. Nobody's letting it, no one gets it right. It took me forever to get it right. It's AACOG, it's the Alamo Area Council of Governments, AACOG, and then it's common. Bear Area Agency on Aging. It took me, I was there several months before I could say that correctly. So if you ever hear AACOG, within that, under the umbrella, it's the Bear Area Agency on Aging. If you ever hear them talk about the AAAs, that's the Area Agency on Aging. Not to be confused with the auto clubs, everybody gets that confused too. Or Alcoholics Anonymous, they get that confused too. So we're going to talk about Medicare Part D today. And before we get started, has anyone had any personal experience with Medicare Part D? Anybody? Has anybody had any training on Medicare Part D? Few? Okay. It's a fun topic, isn't it? And so the ones who have that, they know about it. Now this is not a real long seminar on this. And most of the times when we do trainings with professionals, it's usually at least 2 or 3 hours. So we're going to cut out a lot of it. And even when there's training that's 2 or 3 hours, people usually come back several times because it's so difficult. And I've worked on this for 2 years. What I do for AACOG and a AAA there is, and I've done this for 2 years for them, is I coordinate outreach and education, on Medicare Part D and the low-income subsidy, which we're going to talk about later. I focus a lot on that. And my boss talked to you a couple of days ago, Carol Zernial, and she talked about the AAA. Just know that we're doing that over there. Most of the AAAs do not have the luxury of having somebody working on that, so we're very unique. But it does normally fall under benefits counseling. So if you're out there, say in another region of the state or somewhere else in the country, if you have questions on this or need assistance, you can go to your local area agency on aging if you have questions or need help with Medicare Part D. Just want you to know that. So anyway, before we get started, I just want to say, like I said, this is a very short training. If you will be working with people one-on-one in this or needing working more one-on-one with people, I would recommend that you get some additional training. This is just to let you know what this is. So just kind of let it sink in if you can. And like I said, I've worked with doctors, lawyers, policymakers, all sorts of politicians, pharmacists, and they've all said this is the hardest thing they've ever had to deal with. It's just so complicated. And every time I think I've got this figured out, there's something I haven't got figured out. So just don't worry about it. It doesn't all sink in. And I've thrown out a lot of the details. So a lot of it, you know, just sit back on this. So, okay. Okay. Medicare Part D. Medicare prescription drug coverage. Okay. It's Medicare Part D, or Part D, they'll call it that sometimes, but it's Medicare prescription drug coverage. All three of them is the same thing. Now, oh, another thing I should have mentioned. I gave some handouts. The handouts are not the same as this. I went back and looked at it and I found that I wanted to, that was from an earlier, much earlier presentation. So you may want to make some notes. Some of those, I think there's some things that are incorrect, plus I thought it was just too wordy, and I simplified it a little bit. So Medicare prescription drug coverage is the same thing as Medicare Part D or Part D. So if you hear those, they're exactly the same thing. Well, we're going to back up a little bit on that. We need to figure out what is Medicare. Well, there are different parts of Medicare. And Part A is for the hospital, when you go to the hospital. And Part B is medical. Well, Medicare is for people who you get it by getting so many credits. And it's for people who are 65 and older, or some other circumstances like end-stage renal disease. There are different circumstances. We're not going to go into that a whole lot, but just recognize there's a difference between Medicaid and Medicare. People get them confused. Medicaid is based on, you know, what you make, how much, you know, it's a needs-based thing. People who are on Medicare every year receive, or should receive, this Medicare and You book, which gives information on all the different Medicare programs. And you can download this on the Medicare site, and I'm going to quote this a lot, www.medicare, I think I did too many W's, medicare.gov. And this will give some information on Medicare Part D and all the other Medicares. Thanks. Okay, so Medicare Part A is hospital. Medicare Part B is medical, when you go to the doctor. Medicare Part D, the way to keep it straight is, remember, D for drugs, because it gets confusing. Okay. Now, it's going to seem like I'm going back and forth on this, which I am doing, but just before we get started on this, kind of see where we're going. There's also what we call the low-income subsidy. Low-income subsidy is also called LIS, or extra help, and you're going to hear that a lot. Now, that is a program for low-income Medicare beneficiaries. This works to supplement Medicare Part D. It is not an insurance program. It is not Medicare in and of itself. It helps Medicare Part D. And the rules and benefits are different than for other Medicare Part D beneficiaries. So what you need to get Medicare Part D is not the same as for low-income subsidy. They're stricter. And I know that's confusing, but bear with me. Okay, where did Medicare Part D come from? It came from the Medicare Modernization Act of 2003. And that made several changes to Medicare. It just, and this kind of tell you a little bit where it came from. Changed Medicare Choice plus Choice to Medicare Advantage, and changed several preventive benefits, and then it added the prescription coverage. That's when it all came about. And it came into, and Medicare Part D came into effect starting 2006, that year. Now, the Medicare prescription drug coverage, which is Part D, again, remember D for drugs, is provided through prescription drug plans, what they call PDPs. And there's all these acronyms that will totally confuse everybody. Now, these prescription drug plans are private insurance plans. Totally different than what we've ever done before on that. It's Medicare approved prescription drug plans. These are not, it's not Medicare. Does that make sense? So it's not Medicare's plans. They're Medicare approved private plans for private insurance companies, whether they're like Humana or Aetna or one of these. And they're just their prescription plans. Okay, now you can also get your prescription drugs through what's an HMO or PPOs. They're health maintenance organizations, preferred provider organizations. These are what, if you know, like Secure Horizons, things like that. There are a lot of other HMOs and PPOs out there now. It used to just be Humana and Secure Horizons here. There are a lot of other ones through there. You can get, the drugs can be through that. That gets confusing there because you're saying, well, that's not just a prescription drug plan. Well, they can have their drugs through that. That can be part of the plan. And that's where it gets real confusing there. But there are some HMOs out there, they're called fee-for-services. Some of them do not have the prescription plans in there. That's a whole other topic, and it would be a more extended discussion for this, but just be aware some of them have it. Also, some people have their prescription coverage under employers or unions. Okay, they're already getting the prescriptions through that. Now, I know this doesn't make a whole lot of sense right now. We're going to be talking about creditable coverage. Okay, and we're going to get back to that. Just keep in mind, there's different ways you can do that. It's called creditable coverage. We'll get back to that in a minute. Okay. All plans, all these prescription drug plans, have to offer what is called a standard benefit to be approved. Now, they can offer more, but they have to offer a standard. Okay, now the standard benefit for 2007. Now, keep in mind, things will change. There's always, the numbers change. Everything changes each year. Okay, this year, for 2007, a person with Medicare will pay generally less than $30 a month premium. Now, the premium is what you pay each month to get the insurance. That's what you pay for the insurance. That's also in addition to Part B premium, if you have it. Like if you're paying Part B for your hospitalization. I'm just saying you have another Medicare premium, but it's basically $30 or less. So you pay that each month out to get this Medicare prescription drug plan, and then $265 deductible, which is what you basically will pay before it kicks in. Now, some of the plans don't have a deductible, and that's something people can keep in mind. And then you have a co-insurance of 25% of a drug cost from the $265, which is after the deductible, to $2,400. Okay, so basically Medicare's paying 75%. This is the most difficult part right here, this slide. The Medicare pays 75%. Now, this is the standard benefit they have to do. Now, after that, a person pays, after you get to $2,400, a person pays 100% of the drug cost from $2,400 to $5,451.25. This is what that infamous donut hole is. Has everybody heard of the donut hole? This is that donut hole they're talking about, where when you get to a certain point, you have to pay all your drug costs for a certain amount of time until you've paid out this amount, and then it kicks back into a catastrophic stage. And then the numbers will change each year. In fact, I always have to read because I haven't got all these memorized, and it's going to change again next year. So now after that, when it reaches $5,451.25, then they pay a co-insurance of 5% for drug cost over $5,451.25. Their out-of-pocket expenses will total no more than $3,850, but that really is, that's what they will tell you. That is really not accurate because there are formularies, and if something is not on a formulary, it ends up being more. That's what it can actually end up being more. It really can actually end up being more. But this is the donut hole, and there are just a lot of problems with that. There were some plans in 2006 that came out that you could pay a little more, and they covered the donut hole. Apparently they weren't making enough money, so there weren't any for 2007 except for a couple that covered generics, but no brand names. I'm wondering if there will even be anything in 2008, but we get a lot of caller agencies where people hit the donut hole and they're in a lot of trouble. It's really rough. So this is a very difficult concept to understand, and you hear a lot of reasons that's why, but don't worry about all the specifics on that. Just be aware that there is a point they're going to hit where they hit the donut hole. Most people, unless they're getting extra help, or that LIS, we're going to talk about that in a minute. Okay. This is just a little chart going over kind of what we talked about again for the what Medicare pays for on that, and that chart should be in your packet. I think there may have been, yeah, I think that one's okay. The numbers may have changed on some of that. You might want to look at that on there. That should be on there. That's just going over what we said on it. Let's see. Okay. Here we go with the acronyms again. There's an IEP, AEP, and SEP. There's initial enrollment period. The first initial enrollment period, this would apply to people who were already on Medicare. They should have signed up for Medicare Part D between November 15, 2005 through May 15, 2006. And they could have started, if they signed up before January 2006, that's when the program officially started. Or what they're saying, a 7th-month period encompassing as midpoint the date of Medicare eligibility for individual. What that means is say you got 7 months from the time, say somebody becomes eligible. Say it's like, if you say it's like somebody's 65th birthday. You got 3 months before the person's birthday, the month of the person's birthday, and 3 months afterwards, or if they're becoming eligible for some other reason. And if you have questions on stuff like that, a good place to turn to is talk to Social Security, you know, like Oscar, who was talking to you earlier. He's, you know, Garcia, who was here earlier. He's you know, those people can help a lot, or Medicare, but Social Security can talk to you. So that's when that would be your initial enrollment period. So people need to sign up for Medicare Part D. When they're signing up for Medicare, you don't automatically get signed into Medicare Part D. You need to sign up. So you need to contact our office or contact Medicare, somebody who can help a person pick a plan, because there are lots of plans out there. Here in Texas, and they go by regions, Texas is a region, there are 60 plans for PDPs, and then there's the HMOs too. You can sign up that way too. So there's lots of different things, lots of confusion. And a lot of times people get, a salesperson will get a hold of them and they'll just go by that. And what works for one person does not necessarily work for another one, because they're different formulas. Even though there's a standard they have to go by, there are different things on the formulas. Okay.
Excuse me, did you say that you can start it 3 months before you turn 65?
You can sign up. You can sign up. It becomes activated when you turn 65, but you can sign up for it. Okay. Now, you won't sign up for the plan. You need to sign up. Your initial enrollment period for Medicare, I wasn't clear on that, I'm sorry. Your initial enrollment period for Medicare is, and then when you sign up for that, you sign up for that, yeah. I wasn't clear on that, I apologize. I'm glad you brought that up. Yeah. This is interesting, and this is what I always tell. We did a lot of talks to people, the people in the community. With Medicare Part D, whatever I say, or what anybody says, there's always going to be an and, if, or but, because it depends on your situation. If you are in the category of the LIS, the low-income subsidy, which we're going to talk about, you don't have to wait for that. You do not have to wait for that. And we're going to talk about that. You can do it at any time. You can qualify for this extra help. And that's one reason we do a lot of outreach on it. We're really trying to find these people. Because they have, you know, not only does it get the drug costs lower, but they can get in any time, they don't get a penalty. Let's hit the next one. I'll show you one of the things. But no, that's a very good question. I'm so glad you got me on this on the initial enrollment period. Okay. There's also an annual enrollment period. Okay, this goes to this one. This is where a beneficiary can enroll or switch in Part D. Each year, a person can, between November 15th and December 31st, a person can switch plans, or if they did not sign up when they were supposed to, they have to do that. Like I said, except for those people who can get this extra help. We're going to talk about that in a little bit. Okay, this is his group, the special enrollment period. the SEPs. It's continuous. If people have Medicare who have full Medicaid benefits, so if you've got full Medicaid, not Medicare, but you gotta have Medicare, that's something we keep in mind. This is for people with Medicare. If they also have full Medicaid benefits, they can switch at any time in Medicare savings programs. And that's like QMB, SLMB, QI1. These are things that help pay for Medicare. That's a whole different thing. It's a program that helps with that. If they're residing in a long-term care facility, if they move in or out of a long-term care facility, or if they move out of a plan's service area, which would be like a service area here is Texas. So if somebody moves to another state, or somebody's come from another state and moves here, they can change. Now, there's also, like with the low-income subsidy, the people who are on Medicaid or in the Medicare savings plans will automatically get that low-income subsidy. There are a lot of people who should be on Medicaid or in Medicare savings programs that don't know that they could get it. And we try to find and get them on and give them that extra help. There are some people that make a little more money than to qualify for these programs and still get the extra help. If they apply and get that extra help, they can still get that special enrollment period. They can still get in. They can still get in at that point, which is wonderful. And they won't get the penalty. Because this is what gets everybody. This is another thing everybody gets upset about. What if you didn't sign up by May 15, 2006 or when eligible for Medicare? The beneficiary is assessed 1% of the base premium for every month not enrolled. And it adds up. Now this year, the base premium they consider is like, it's 26 something, I can't remember now, it's like $26. So it's 1% of that for every month, you add it up. So it's like 26 cents added up for every month, and it's compounded, it just adds and adds and adds and adds up. So it's not so bad if it's a month or two. Let's say you let that go 5 years. It can get pretty high. And then for the rest of your remaining years on Medicare, you add that to your premium forever. And then one of the problems is because you can't run out, unless you're in that getting the extra help, you can't just run out the next month and sign up for it. You have to wait until the open enrollment again. So you want to really make sure that you get in there when you're supposed to. Okay. And I will check down. There is an exception for beneficiaries who have, quote, creditable coverage. They will not pay a penalty if they wait to join a plan. Okay, another one of those things. What is creditable coverage? Okay, let's look at creditable coverage. Creditable coverage. This is some employers' group health plans. Like if you are federal employees, state employees, most teacher retirement, there's some that aren't on there. Some companies have it, some don't. There's several things out there. And they would send a letter to you saying it's credible, meaning it's as good as or better. And they're supposed to send you a letter every year, but they don't necessarily. Sometimes they put it in the employees' benefits packets or something, but they're supposed to send that. State pharmacy assistance programs, we don't really have that here. The other thing is like the state kidney health, they have some stuff. Veterans Affairs is the VA. VA is the only time you can actually have a Part D plan and VA. You can do that because you can't have a Part D plan and usually another plan. Doesn't work. But VA you can. VA is the one time you can do that. If you use VA doctors, you get their prescriptions through the VA, and if you are using a doctor on the outside, you can use an outside pharmacy. So if you've got something with VA, just take it up with them, but you can do it. TRICARE, that's great creditable coverage. They don't need to be doing Part D, just stay away from it. And then also the creditable coverage, yeah, they're saying an exception for beneficiaries eligible for extra help. They're fine with that. They're not going to, actually, I probably should have put that under creditable coverage, but they don't have to pay that, penalty. But that should have actually been under creditable coverage. But what I'm saying is you can't have both B and other. usually D and other plans. In fact, people were signing up for D and they're getting thrown off of things. It just always check with the companies just to see if it's credible. And sometimes it'll be credible 1 year and then they may drop the plan. And if the reason you want it to know if it's credible is if a company, say company A, decides they're no longer going to offer benefits and they're going to drop the prescription coverage, and this is, say, a private company, and they say, well, now I've got to go get Medicare Part D. Well, you need to show that you had something that was as good as Medicare Part D, so you won't get that penalty. Then you can show it to Medicare and say, see, I had something that was just as good, so I don't get this horrible penalty, especially if it's 5, 10 years down the road, because you have this horrible, horrible penalty that, you know, stacked up on your premium. So you want to make sure that you have, you know, all that lined up and you pass that information on to people.
Okay, so if you have TRICARE, you still need to sign up?
No. Let's go back. See, this is where it gets really hard. Okay, if you have creditable coverage, you do not need to sign up for Part D, but you need to have, now this really wouldn't be true for TRICARE.
Okay, because I'm in TRICARE.
Okay, you are absolutely fine. You got the best stuff going. But if you say are in a private company and they're doing prescription coverage, you really need to get a letter saying that it's creditable coverage. They're going to use all different types of terminology. They'll say it's as good as or equal to or something. But CMS Medicare gives them things that they recommend how they do it, but they don't require them, which I wish they would, to say this is what we want you to say. But you need to hold on to that. And then if for some reason they drop it, TRICARE's not going to drop that. I mean, if they drop that, we're really on trouble. I mean, they would be like the last one. But you want to make sure that you have it. So if for some reason they drop it, you can prove to Medicare that you had this credible coverage, you were covered during this period, so you don't get a penalty. But TRICARE, I mean, you do have that in your stuff. They would send that to you, but you're fine. So TRICARE, if you're federal or state, teacher retirement level 2 and 3, 1 is not. Actually, if you know anybody, it's TRS 1. That is not creditable coverage. And there's several others, you know, just call and check, call the benefits person for the company and just say, I need a letter saying that. So, and just like I said, check it every year on that. Does that make sense now? So, like I said, then when you do change, if you have to change, because some of the companies may at some point drop that because it's becoming expensive. But actually, surprisingly, I read a study the other day that they aren't dropping them. The private companies actually are not dropping the prescription drugs. I thought that benefits, I thought they would. They were predicted to do that, but they aren't as much as we thought. Okay. Now we're going to get to the extra help, also known as low income subsidy or LIS. Okay, this is assistance with the premium up to the national average and is cost sharing. Okay, hold on. Administration important information. Our records show you need to be eligible to get extra help paying for your prescription drugs. Okay, I just was wondering if you'd seen that. Okay, because people get confused about this and think this is for Medicare. The LIS, what this is, like I said, it's assistance with premium up to the national average and cost share. It's to help low-income people with their Medicare Part D costs. The eligibility for this is determined by Social Security. And this totally confuses people. So they'll get all this stuff from Social Security, and they send a whole bunch of these out to people. Sometimes they went to people that needed it, sometimes they went to people who didn't need it. They were really trying to guess. And the applications, you know, you fill out a bunch here. Now they do it pretty much all online. And they determine it by your income and your resources. It's not as strict as applying for Medicaid. The income, it's below 150% of the federal poverty level. They have different levels of help, and right now it's for an individual it's $15,315, and for a couple it's $20,535, and the assets for an individual it's $11,710, and a couple it's $20,410, and the assets go up with the dependent family size. This is none of those and if or buts again. And how they look at your assets, like I said, it's much more flexible and lenient than Medicaid. They don't count your house, or Medicaid doesn't count your house. Yes, ma'am.
I'm sorry for all the questions. But say, for example, that you were living with your daughter or your son or something like that, and you don't even have a job. I think you're getting your Social Security. Do you automatically qualify for that, or do we have to present our income, our earnings, because you live with us?
It depends on it. If you're presenting yourself as a family unit, it's one way. If you're presenting yourself as like roommates and like you're paying rent, you know what I mean? It's how that's one of those that kind of comes out different ways. It's how you're doing it. If you're doing it as roommates paying, like say there's 2 people in the house, and say the rent would be for the house would be equivalent like $500. If she's paying $250 and you're paying $250, then you can say you're roommates. If it's a family and you're paying nothing, or
she's not paying.
So then you would have to say you're providing some assistance for her.
Okay, so my mother-in-law moved in with me, and she's not paying anything. The only thing she's getting her Social Security. Would she qualify for that?
It depends. You have to look at the whole picture. That's one of those you have to look at it by, but you probably have to say she's getting some help. Now, is it her house or your house?
My house.
Okay. So you have to look at it. That's where you have to sit down and look at the whole situation. I really can't look at it like that, but you do. Every situation is a little different, but you do have. They do look at if you've got some outside help coming, if you're getting help, and every family situation on that. Okay. But they do, you know, the house is exempt, things like that. It is much better than Medicaid. It's not as strict as Medicaid on assets. You can have a lot more. Well, first of all, you can have a lot more assets than wise. Okay, and the people who automatically get extra help are the people with Medicaid. Medicare get the full Medicaid benefits, get SSI. The people who get help from Medicare paying their Medicare premiums. Those are the Medicare savings people we're talking about, the QMB, SLMB, and QRO. Okay. All others must apply, and that's what the applications, that they're better online. And also the people who need to be getting the Medicaid and the SSI and the QMB and SLMB. There are lots and lots and lots of people we can find who need those programs, and they really, really help them because it helps them. They don't have to pay that $93.50 each month out of their pocket for Medicare, and then also it helps with those co-pays. It gets them to the doctor more. Okay, this is a chart on low-income subsidy groups, and this gets real confusing too. Don't worry about all this. There are 4 different groups again on here. You have like a group 1, group 2, group 3, group 4. The premium, the national average premium is like what they're using is $26.90 a month. You have the lowest group in terms of what you can make, what they call like the full duals. You'll hear that one a lot. Full duals means a person who's on Medicare and Medicaid. So if you hear somebody, that's used a lot. Full dual, the person who gets Medicare, Medicaid. Okay, not just Medicare Part D. You're going to hear that one a lot if you're out doing this. And they pay, this, like I said, this is group 1. Go down there. They pay 0 premium. They don't pay the deductible. If they're in an institution, like a nursing facility, they pay 0. Where you see this $1, and actually I should have done that better than that. $1 for their drugs, it's generic, 3/10 for brand names. So that's a good deal. Okay? You see group 2? QMB, SMB, QI1, SSI without Medicaid. Okay. 0 premium, 0 deductible, $215 generics, $535 copay. And then also when they get to mention that catastrophic where the other people would be going out of the donut hole, they're 0. See, these people don't have a donut hole problem. That's another nice thing about this. They don't have a donut hole problem. You see how they have group 3 and group 4. There's that group 4 one is the one to look at. It has a sliding scale. Those are the ones that make a little bit too much for the Medicare savings and all that. They have a sliding scale on their premium where it's less than the $26.90. They have a $53 deductible, but it might not even be that much. It might be in a plan that doesn't have a deductible. They pay 15% co-insurance during up to the $38.50, so they don't have the donut hole. And then when they go into catastrophic after the $38.50, they pay $215 generic, $535 randoms. Now, one thing we have to remember is, because of the way the formularies are, if you don't pick a plan that covers your drugs, you're not going to get your drugs for those prices. You're going to pay the regular price. So it's very important to pick a plan that has the drugs. This is only if you're on a plan that covers your drugs. Does everybody hear me on that? Because this is only when it's working the way it should be working. So one of the things is I'm not a pharmacist. I'm trained in gerontology, so like if anybody's in the pharmacists, they probably explain this better. There are different categories that they have, different classes of drugs. And the way Medicare says, they said you have to cover these different classes of drugs, but you don't have to carry all drugs within this class. Say there's 3 drugs in this class, assuming there are 3 drugs in this class. You can cover 2 of them, but you don't have to cover the 3rd. So plan A, they cover 2 of these, the next one will cover these 2, the next one will cover these 2. So it gets really difficult sometimes to pick a plan that covers all of your drugs. Now you can do what is called an exceptions with your doctor. The doctor will write in doing exceptions. Sometimes that works, sometimes it doesn't. I've got a lady I'm working with right now who's on a plan who's getting the extra help, who is still paying the extra $190 a month because her plan refuses to cover 2 drugs, even though her doctor's been writing all these exceptions letters. And I thought, this is a lady who should be paying $215 and $535. So it's really a mess. So it's like it's best if you can get on the plans that cover them to begin with. So we're trying to help her. So I was saying, if you can get on a plan that covers to begin with, it's better. But just keep in mind. So that's why it's good to do the plan fund, which we're going to talk about in a little bit. If I hurry up real fast, let's see. Okay. How do you apply for the extra help? Well, you apply online at Social Security, which is basically this application, ssa.gov. Or you can apply online through Benefits Checkup. And I brought some pamphlets on that. This is the only connection to Social Security site that Social Security allows. And Benefits Checkup is a wonderful, wonderful, hold on here. Organizational edition that we do locally, if anybody's interested in doing that. And this is a website that provides all sorts of programs, checkups and programs for all types of things they might be interested in. And they have a connection. And the nice thing about this connection is it will also screen for other things, like they have full screening for all types of things. But if you do the screening for the LIS, low income subsidy, or I'm saying when you fill it out, it automatically asks a couple more questions. It'll also tell you if this person is probably qualified for Medicare savings. And so it catches a lot of people. And like I said, if you're interested in an organization here, and you're interested in an organizational vision, our agency's doing it. There is a cost associated, but we assume the cost. So if anybody's interested in that, please do this. So you do one of these ways. Now, Understand, when you fill this out, all you're filling out is the low income subsidy. You're not filling out for Medicare Part D. This is just for the extra help, okay? Okay. You also can fill an application out at the Social Security office. That's fine. You can do that. That's a great one. Go to Social Security. The paper application can be used, but they really don't want you to do that. Or you can contact your local SHIP, which is State Health Insurance and Assistance Program, or Area Agency on Aging. We actually do both, the Area Agency on Aging. You can call us, and we'll be happy to do it, because we're looking for those people. That's what we're here for. So you can do that too. Okay. Part D plans must cover cancer medication, HIV/AIDS treatment, antidepressants, antipsychotic medications, anticonvulsive treatments for epilepsy and other conditions, immunosuppressants. Okay, you don't need to memorize those. Excluded drugs. Okay, just kind of anorexia, weight loss or weight gain, fertility, cosmetic purposes or hair growth, symptomatic relief of coughs and colds, which, anyway, prescription vitamins, mineral products, except prenatal fluoride, non-prescription drugs, barbiturates, and benzodiazepines. We've had a lot of people, especially because the benzodiazepines aren't covered, and that's caused a lot of problems for some people really needing that. Okay, these are just some helpful tips. Clients should not sign up for the first plan presented to them. You should shop around, make sure the plans selected meet their medications and pharmacy needs. The lowest premium will not necessarily be the least expensive plan. And Medicare has a wonderful site on their www.medicare.gov. I think I have it at the very end, where you can go there with the plan finder, where you can go and put in a person's medications, and it will show you all, compare the different plans, and it will really help you figure out which plans are better for the person. And it will show you, it's a lot better if somebody saw it like last year compared to this year. It really does a really good breakdown now, comparing even month by month, showing what the cost will be. It's a much better tool than it was. I think it's really good now. So don't just look, because some people will look and say, I want the deductible, I want the cheapest premium. Yes? Hi.
Before, it says to look for the best plan. If people were like in Secure Horizons, I remember that they were telling people that if they chose a different plan, they'd have to be dropped from the Secure Horizons. Because you had to have your coverage with
yes.
Right. So you don't always get the best plan, nor are your medicines covered if you're in the HMO. Is that still the same way it is?
You can do the LIS, that's nothing. You can get the LIS, you can get the extra help with the HMOs. But you're tied with the fee-for-service ones. Some of the fee-for-service ones, they have Part Ds that are standalone. But yeah, if you are in an HMO, you have to use the standard HMO. You have to use the prescription plan that's theirs. So you have to take that into consideration. In fact, one of the things that you have to keep in mind is if you're in, say, Secure Horizons and you go sign up for a Part D plan, you're going to get kicked out of Secure Horizons because you can't have both. So it's really confusing. So yeah, that's a good point. So when you look at it, you have to look at it as a package. So if you're saying, and I'm just saying Secure Horizons because that's the one that came out, there's a bunch of different HMOs out there. You have to look at all of them. You have to say, are my prescriptions in there? Is this what I want? And then look at the other, benefits that come in that. And yeah, a lot of times it's a trade-off. It's a trade-off on that. And we deal with that some. Okay, and that's running the plan finder. And also, not all plans with the premiums with the national average offer full low-income subsidy. You have to pick a plan. Only some of the plans accept that low-income subsidy. And also, drug is not on a plan. Consider researching PAPs, patient assistance programs, and the benefits checkup we're talking about here. They have them on there. Patient assistance program. They have a really good way to look up drugs, because sometimes you can find free medicines through the pharmaceutical companies. Some will help you if you're on Part D, some won't, but some of them are now helping on there. Okay. Just another helpful tip, a plan is good for one person and not necessarily good for another person. And just plans vary on their formulas. And sometimes you'll get these people say, well, my husband's on Blue Cross, I want to be on Blue Cross. It's like, no, don't look at that, because different people take different drugs. Also, next year you may be taking different drugs. So your plan may need to change. Plus the plans change. Some of the plans are gone, some of the plans, they change their formularies. That's another thing. They can change their formularies. And they just can tell you in 60 days, you know, it's like they can do all sorts of stuff, so you have to keep on top of that. Yeah, and to change a plan, you don't disenroll in a plan. This is another thing. You don't disenroll. This goes against everything you would think. You enroll in another plan to disenroll from a plan, because you're given a shot to change, but they say that's your choice. You only have one choice. So if you're in Plan A, you want to go to Plan B, you don't disenroll in Plan A. You just sign up for Plan B. And a lot of people, I know it doesn't make sense. You can just get into a lot of trouble. It doesn't make any sense. So, like I said, I'm recommending if you really work with people in this field, with Part D, get some more information. There's additional training. There are a lot of good websites out there. If you have any questions, you know, 1-800-MEDICARE. And when you call 1-800-MEDICARE, I got to tell you, sometimes they had to hire a lot of people. And sometimes you get people who really know what they're doing, and sometimes you don't. So it's just kind of hit and miss. But if you're really having a problem, sometimes you can get people further on up. You can always call your local area agency on aging here, or if you're in another part of the state or country, you can always call there and call, you know, ask, well, even here you can ask for me, but other areas you call for asking for the benefits counselor, and they can help. Or you can go to your Social Security for the low-income subsidy for help on that. There's additional training on Medicare Part D in the Medicare.gov, that www.medicare.gov website, and I didn't put the, let's see, the Medicare Rights Center website, I didn't put the, oh gosh, sorry, I didn't put the website on there, but Medicare Rights, I think it's www.medicareRights.gov. And they have a real good one, and if somebody's interested in that, they can email me and I'll get that to you. My email is dlong at AACOG, and it's AACOG .com, C-O-M. Okay, and also our agency, we give training on Medicare Part D from time to time that goes more in depth, and we can help more one-on-one. Okay, and just please remember, don't stress out if you don't understand all of this. It is very, very difficult material. Okay? Okay. Yes?
Just as potential advocates for elderly, and this is such a complex issue, anything that we can do at a larger level, congressional, legislative, local, to help out elderly with this situation?
Yes. You really interested? We're doing, one of the things we're doing, our big thing we're taking this year, is we have a huge outreach locally. If anybody's interested in helping really use it, is we're doing an outreach to try to find people who qualify for low-income subsidy. And we are actually, have a mapping center within the Allen Area Council of Governments. We have identified homeowners that are elderly and people who are disabled, that homes are below a certain value. We're actually targeting certain neighborhoods and sending out flyers saying we'll be in your neighborhood. We're going door to door, trying to find these people. But we desperately need volunteers who have background checks. And that is part of the time. Because we want to make sure that we don't get people in there that are going to hurt people or hurt the other volunteers. So that's one thing, is that's going on as we speak, both here and also in the 11 surrounding counties. In fact, we got something going on in Broncos Friday. So that's one thing. Another thing is just
be very active. We have it's called the Access to Benefits Coalition. If you're interested in joining, I can get you some information on that, or just email me on that. There are a lot of partners like Social Security, the City of San Antonio, University Health System. Carolyn's real good on it. They're great at it. For low-income Medicare people, we're really trying to figure out how to help people with this, how to get the word out, and contact your legislators on this. If you see problems with this, a lot of it's like, how do you see this as far as like, what's your take on how you want to help?
Well, I'm seeing that the very poor have outreach services, and the ones at the higher socioeconomic level can afford to have and ask for help. It's the folks in between, the ones that I see struggle, a 65, 70-year-old that's pretty independent, is having some confusion around this and doesn't really quite get all the different things to do. So that's the first thing I'm thinking of. And I'm having a hard time understanding.
Well, we also have our agency. We always are looking for benefits counselors, volunteer benefits counselors. We have a great training you go through. It's like benefits counseling, not just for Medicare Part D, but Medicare, legal, Social Security, all the different aspects. And then you're a certified benefits counselor, which is wonderful, wonderful training. And then you help people with that. And that SHIP I was talking about, state health insurance and assistance program under the state, and you get trained for that, and you can volunteer with that. Actually, we've got it now for our first outreach placement. We're going to have people over Bob Ross. So we're going to have people over there within our office. We desperately need people to help with these issues that are coming up. We'd love to have somebody with that, and we help all different income people. People call in on the phone or going to different sites, getting talks. Desperately, if you're interested in that.
Is there any movement to fix this thing so it's not so complicated? Legislatively, Congress wants to fix it. Does it work right, or you're happy with it?
I hadn't heard as much lately. Last year, and then this year, CMS's big thing, Medicare's big thing is preventive services. Medicare D just kind of got that they're on to something else now. So we're not getting that much out of Medicare now. But as far as the legislators, we're not hearing as much. The big thing we were hearing was more, it's not directly, this was making it where if you're on disability, you didn't have to wait so long before you could get Medicare, because that was so ridiculous. Having to wait for 2 years to get Medicare. And I know there's been some push on that. And that's very important. And that's something that you want to.
Well, that's what my biggest concern is. We're talking about probably the most vulnerable
Yes.
group.
Don't have internet access. Don't
I know, that's something that's always, there was,